Well, it's very nice to have Geoff Brown today, and I've been looking forward to this paper of his very much. Geoff, as a lot of you will know, works for the adolescent unit Simmons House for the North East Thames region, and his work is with adolescents, as far as I can understand. And he's going to do a paper on borderline states, incest and adolescence. And, look forward to that.
Right, shall I get going?
I think so, yes.
Will people let me know if I need to speak up so I can get that right? Well, this paper is derived from my experience in an NHS setting where severely disturbed adolescents are treated on psychodynamic principles. The scope implied in my title could be almost infinitely wide, but my aim is the more modest one of sharing some ideas that provide connections between all three elements. For some time I've been interested in the occurrence of borderline functioning within the adolescent phase of development, both as a manifestation of psychopathology and as a characteristic of normal adolescent psychology. During the past few years, an additional factor has emerged alongside the more usual aspects of severe disturbance in adolescence, which has made a great impact on my own clinical setting, as it has on most others where children and adolescents are the focus of therapeutic attention. This new factor is a history of sexual abuse in childhood. From a relatively peripheral issue, child sexual abuse has come to occupy a central part in our daily work. It now occurs either as a finding secondary to referral for a wide range of psychiatric and behavioural disturbance, or as the primary reason for referral. In 1990, 33% of new cases were known to be victims of past sexual abuse. Currently, over half the adolescents in the treatment programme have a history of child sexual abuse. This in itself is no longer outstanding. Most agencies working with adolescents have similar figures, and in children's homes estimates have been even higher. This change has produced a number of challenges in clinical practice, in interaction with other agencies, in interaction with families, and in the therapeutic relationship with the adolescent patients. The widespread contemporary attempt to respond to this phenomenon is producing repercussions on many levels, from child-rearing practice through social legislation to re-examination of theoretical formulations. Much of this has produced pain, controversy and confusion, a collective attempt to assimilate an aspect of collective shadow. My experience of working with a number of patients in whose pasts sexual abuse has been a major feature of a generally adverse environment has stimulated a need for my own reappraisal of the part played by the external world in shaping development. In this paper, I will explore the impact of sexual abuse on development, with reference to the adolescent life stage, and provide some illustrative material from the therapy of a female adolescent patient. Before proceeding with the case material, I will first refer to a paper by Breer in which he presented the results of a survey on a random sample of adult female walk-in psychiatric patients. He found 67 women out of 153 gave a history of childhood sexual abuse, and that these were statistically more likely to be taking psychoactive drugs, to have a history of alcohol or drug abuse, to have been the victim of battering in an adult relationship, and to have made at least one suicide attempt when compared to the non-abused group. In addition, the sexual abuse victims were more likely to report dissociative experiences, sleep disturbance and nightmares, feelings of isolation, impulse to self-injure, and fear of men or women. He referred to this pattern of chronic symptomatology as a post-sexual abuse syndrome, and pointed out the similarity to the phenomenology of the borderline personality disorder as described in DSM-3. Well, I'll proceed now to present the history and therapy over 6 years of a female patient whose pattern of dysfunction included most of those symptoms in Breer's list and who presented typical features of adolescent borderline personality disorder. Amy is the eldest of 2 daughters of a black father and a white mother. When she was referred to me, aged 16 years, following a serious overdose of paracetamol, I found she was surrounded by professionals, each with a special helping relationship to her, and largely unaware of each other. They included an education welfare officer, an individual psychotherapist, a child psychiatrist, and her general practitioner. She had a long history of disruptive and disturbed behaviour, which dated back to her first entry into primary school. This pattern of a group of concerned adults paying her special attention had been established early in her life. But exploration of her story soon revealed a parallel group of people who were bad and persecutory figures. All along there had been those who, like one early class teacher, felt that she was an impossible and malign child, while the other group responded with protective indulgence and thought her to be misunderstood. Her problems, primarily school-based, to begin with, had escalated over the years from disruptive behaviour through fighting and damage to school property to alcohol and solvent abuse and stealing. Special placement in an off-site unit, intervention by the Education Welfare Service, and 2 years of individual psychotherapy from 14 to 16 years had done nothing to abate the worsening of her record. Her referral followed a period of strife in her relationship with her mother, almost continuous intoxication and chaos culminating in the serious overdose. In the first assessment meeting, she came with her mother, who appeared fraught and depressed. Amy, on the other hand, displayed her ace card, a truly warming and beatific smile. She wore rather boyish clothes and was a little chubby. In the first individual session, she presented herself with a mixture of serenity and good sense, saying she needed help to stop drinking. However, she added that she drank to be rid of her other self. It's as if there are 2 of me. The other one takes me over, a monster who no one can help. Amy had been born when her mother was 19 years old and her sister 18 months later. Her parents had never married and separated finally after a stormy relationship when Amy was about 10 years old. Her mother worked in a preschool nursery and had been a struggling single parent for much of the time. Her perspective was one of bewilderment and exasperation. She claimed never to have understood why Amy had been the object of such consternation at school. At home, she said, Amy had been a good and supportive child up to about 14 years of age. Since then, their relationship had become a source of anguish and despair to her. She had had an unhappy childhood and an equally troubled relationship with Amy's father. She appeared to be hurt and depressed, both by her abandonment by her man and by her daughter's behaviour. The other child, she asserted, was perfectly normal. While there was plenty in this story that pointed to adverse factors in Amy's early and current environment, after admission she began tentatively to disclose a long history of sexual abuse. Her disclosures were made in the context of weekly individual psychotherapy sessions. This content did not begin to appear until some weeks had elapsed and continued to emerge intermittently over subsequent months. Disclosures revealed a pattern of sexually abusing relationships with men from the age 5 years onwards up to the time of admission. She began with a peripheral anecdote about a park keeper, a stranger. When aged about 10 years, her parents had separated, and to avoid her mother's destructive misery, she wandered sadly in a local park. The man appeared kind and friendly and took her into his keeper's hut, where he pressed her into a sexual act. This anecdote, the first disclosure of child sexual abuse she had ever made, has 3 levels of significance. Firstly, as a statement about an external event, a communication of a fearfully kept, guilty secret. Secondly, it can be viewed as a communication about transference. The therapist appears kind and invites the troubled girl into his room, but what are his intentions? How will the contact develop from here? Thirdly, the anecdote can be viewed as a sort of screen memory. Like the content of a dream, it tells of an internal structure, a pattern of object relations. These differing levels of meaning, common to all communications when viewed psychodynamically, have a special importance when working with victims of child sexual abuse. The patient's past experience of the transgression of boundaries by the actual behaviour of adults surpasses that of non-victims. The weight in terms of internal versus external has a different balance. The first level, that of the communication of a factual event, may have statutory child protection significance and therefore raises ethical dilemmas for a therapist. At the second level, the exploration of transference, the possibility that the therapist's intentions are in fact sexual and that the interaction will proceed toward a sexual act is not only a fantasy, it is a real possibility when viewed from the patient's model of what happens in a dependent relationship with an adult male. Now, this early phase of my work with Amy took place in the context of her admission to the more or less safe and holding environment of the inpatient therapeutic milieu. Much more was going on outside the sessions. While the content of sessions, including the material which constituted disclosure of abuse, was largely without affect, Amy's behaviour on the ward included episodes of destructive acting out, sleep disturbance, nightmares, and visual hallucinations, the manifestations of her other self. Escalation of these features both preceded and followed disclosure of past abuse. To begin with, Amy disclaimed any feelings associated with either session material or the disturbed behaviour. She took interpretations of her acting out as meaningless curios. After a day in which she had continually disrupted nursing staff in their tasks until they began to feel angry, I suggested she may be feeling angry inside. She considered this and responded, "I don't have any feelings." This intense dissociation from feeling states was pervasive and consistent. In time, her disruptive, aggressive and destructive behaviour gave way to episodes of fearfulness, especially at night. Fear, then, was the first and very much unwelcome feeling which she identified as belonging to her. Some time after telling me about the incident with the park keeper, she was able to indicate that there was more. The anecdote was, in effect, a signpost, and therefore acquired a 4th level of significance. From about 12 years of age up to the point of admission, she had been regularly sent to babysit her mother's sister's children. Their father had left the family years before, but Amy's aunt had remarried and somehow the babysitting came to include spending time with her uncle once the small children were asleep. What occurred is a disturbing story of perverse physical and sexual abuse with a marked sadomasochistic quality. After a brief lull, her level of disturbed behaviour escalated and entered even more destructive and self-destructive phase. With great difficulty she moved towards facing the central trauma of her early incestuous relationship with her father. The facts of this were unclear to her, and appeared as if poorly recalled fragments of a bad dream were emerging only to be rejected. She was inclined to resist and repress these memories, and an intense ambivalence about disclosure developed. At times she appeared to have forgotten what she had recalled, and at times she remembered only to say that it was lies or that she was mad. In terms of reconstruction, it appears that, once her sister was born, this child became her mother's favourite, and the parents' relationship deteriorated. Amy became her father's pet, and a sexual abuse pattern began when she was 5, and continued for at least 4 years. Her position was fixed, as a child in between a hostile and non-empathic mother and an abusing father. The role of the adolescent unit as a container for her chaos, pain, anger and helplessness cannot be overstressed, especially during the first 18 months of treatment. Between sessions, the chaos often spilled out into disordered behaviour of many kinds. However, as this was largely held within the unit team, who were in close communication with me as her individual therapist, it was possible to avoid the myriad diffusion and splitting which she had employed as coping strategies for survival prior to admission. The unit, as a safe container, also separated her from current abusing adults, providing an environment which at first aimed to meet her needs in concrete ways: control over visitors, staff who, as well as being non-abusers, limited destructive acting out against themselves or the patient, and the provision of a safe context for interaction, stimulation and play are positive features of the institution. They can be seen as aspects of a good enough maternal environment, which eventually takes on a symbolic function. Internalization of this experience was, for Amy, a slow and painful process, and was mediated by the individual sessions. A dream, after about 9 months of treatment, brought a reference to the quality of the maternal transference. One good memory from the past had been fishing outings with a safe and caring uncle, and the dream was as follows. I come to a beautiful pool in the bend of a river and realise this is a fine place for fishing. Many others have seen the value of the spot and are already happily fishing. They are mostly young, about my age, both boys and girls. They seem happy and excited as they fish. Longing to join in, I prepare my tackle, but when I make the first cast, my body feels strange. I try again, and have the same frightening feeling. It's as if my arm is coming off my shoulder. I feel as though my body is splitting apart, though I feel no pain. I realise I cannot fish, and feel upset. I see my mother standing near, and tell her what has happened. She approaches, and, without a word, moves to touch me. I think she wants to see what is wrong. She touches me with her fingertips on my chest. Her hand seems to slide right into me, making a great hole. Inside I realise I'm quite hollow, and draw back from her in panic and revulsion. While this dream had a nightmare quality for Amy, It was different from the many terrifying dreams of nameless fears that caused her to resist sleep, and yet were beyond recall by day. This was a dream that she could recall and communicate to me. She was also able for the first time to join with me in thinking about the content. Her first association was with sad thoughts she recently had had about her plight. Just turned 16 years, she saw other adolescents around her getting on with their lives. They are able to take advantage of the good fishing while I'm not. I don't understand what has happened to me. I asked her about the mother in the dream, and she said she had never let her mother touch her for as long as she could remember. She was able to accept my interpretation that she felt there to be a danger in turning to me for help with her damaged part. My attention and closeness brought fear of further intrusion and damage. In this dream, both the age-appropriate developmental challenge and the contact with a maternal object threatened the fragile cohesion of a false self-structure, exposing both a split and empty self-image. Following this dream, her warm and endearing smile began to fade within sessions, to be replaced by a sullen, depressed expression. Most of the content came to focus on her night fears and general free-floating anxiety. In the session she was often inarticulate and frozen, and occasionally found it very difficult to leave at the end. Outside sessions she continued to be very difficult to contain, exhibiting intrusive or provocative behaviour. In the counter-transference I experienced an empathic connection with feelings of pain and fear, and felt organised to create a calming, soothing and safe experience for the child within the adolescent. When I spoke about the fear in this inner child, that I would either hurt or sexually use her body, or abandon her, she responded by expressing hatred of this inner part. "She's bad and crazy and should be killed," she said. For a long time, her behaviour reflected this self-destructive inner state of division. Despite this sense of being held, a sense of being held emerged, and with it came the disclosure of abuse by her father. During this period of her treatment, she was out of contact with her father, as he was serving a prison sentence for unrelated reasons. Once she had begun to acknowledge the fact of her incestuous experience with him, she quickly moved from perceiving him as a feared figure who had enforced her compliance and silence by threats. She began to express feelings of emptiness and longing caused by his absence. She described him now in glowing terms, attributing to him a warming, vitalizing quality. Like golden sunshine, she said. She was filled with guilt and remorse for having exposed their secret, and began to retract the disclosure. The numinous quality of the father imago was strongly present, and for a time organised all the other material. Thus Amy appeared to be split into a child longing for her spiritual emptiness to be filled by a godlike father, and an evil, demonic or insane part that claimed or imagined that she had had a sexual relationship with him. I was experienced by her as split in a corresponding way. On the one hand, there developed a positive transference with a psychotic quality, and on the other I was experienced as being in collusion with the guilty demonic child who spoke of carnal incest. Turmoil and confusion reigned, and different oppositions were constellated in which I felt either as a potent source of good or an intrusive source of danger. A dream in this period illustrates some of this painful confusion which overwhelmed the patient's fragile ego function, producing visual hallucinations. In this nightmare, she dreamt of being attacked and raped. In the struggle, she could not at first identify the assailant, but only knew it was a man. At the height of her helpless submission to the rape, she caught a glimpse of his face. It was that of her trusted female nurse key worker, towards whom she had begun to show a dependent attachment. Much of this inner chaos, in terms of inconstant and split objects, was enacted with a variety of people within the therapeutic milieu of the unit. A person whom she had appeared to trust became feared. Someone to whom she had turned as a good maternal figure was suddenly the subject of an attack. In the sessions, I tried to operate as an auxiliary ego, commenting and confronting, and when possible making reference to the confusion experienced by the child within. A sudden pang of anxiety over a pet guinea pig left at home in the care of her mother and recently fallen ill formed an opportunity to interpret the plight of the enraged and neglected baby within. Very slowly, the chaos began to subside, to be replaced by a strong attachment to me and to the unit as a whole. Acting out became more focused onto holiday breaks when I was absent, and ultimately onto the issue of her discharge from inpatient status. Her attempts at controlling me and the staff through manipulation of her self-destruction took on a more obviously goal-directed quality. For many months following her discharge, her panic and fury at the sense of abandonment dominated the continuing psychotherapy sessions. At times, respite admissions to adult psychiatric hospital were needed. During this phase, she came to outpatient sessions with stories of further self-destructive behaviour involving alcohol abuse and theft that caused her to face court proceedings. Frequently she returned to the unit in a drunken, aggressive state, demanding readmission. It took many months of interpretation of this angry attack on me and the unit as representing her anger with abandoning parents before this behaviour subsided. After the discharge, Amy lived with her mother, living out an enactment of concrete dependence. Eventually, however, she was able to express her anger directly to her mother, and during the ensuing months of depression, she moved away and began, with great difficulty, to live in a flat on her own. A dream in this phase, by now the 5th year of treatment, is of interest. She said, I returned to my flat to find a stranger in my living room, an unpleasant-looking man. I protest that he should not be there, but he takes no notice, and in an enticing way he offers me some food from a bowl. I look in the bowl and see some foul, rotten material, and shrink back in horror and nausea. I rush out to find my neighbour, a nice middle-aged woman. When I pour out my story with disgust, fear and outrage, she appears unconcerned. She returns with me to the flat. The man has died and has become a rotten corpse. The smell is foul, but the woman seems to be saying, so what, why all the fuss? I am desperate to get it out of my home. This dream still has a horrific, nightmare psychotic quality, but has many redeeming features which I wish to comment on. I did not take up the content with the patient in terms of transference, as to have done so would have risked damage to my role as a dependable good figure and auxiliary ego. In the context of pursuing goals towards the promotion of separation individuation, it was better to invite her to think about the dream as a statement about her internal world as it relates to the past. At first she was overawed by the dream and felt it to be an expression of feeling haunted by an outside evil that would never leave her. Eventually she could begin to think about the interpretation which I offered along the following lines. This is sort of a paraphrase, something like this. I said, "The dream is about your abuse in childhood. An intruding father offered you some food, as if it were good and sustaining, but it proved to be corrupt and damaging. The mother figure to whom you wished to turn appeared not to empathise with your feelings and ignored your attempt at communicating about your plight. Now this father figure has died and leaves bad feelings inside, but no longer has the power which he used to have when you felt him to be the golden sunshine or the overpowering abuser." In contrast to the much earlier dream of the rapist mother, this dream involves a much greater sense of differentiation and structure. Now there are three distinct figures: a rotten father image, a non-empathic but basically harmless mother image, and an ego dreamer. The action takes place in a space that has boundaries and subdivisions, but the dreamer has the power to move between these spaces and to voice protest, to refuse the offered bad food, and, in the telling, to experience a range of affects: outrage, fear, disgust, and so on. After discussing the dream in this sense, Amy remarked that she recalled how when she first came to see me, she did not know what feelings were, but now she is all too familiar with a whole range of them, nearly all unpleasant. Amy is still in treatment, in her 6th year of psychotherapy. She faces the need for ending with misgiving and recognizes that her abandonment fear remains a dominant inner construct. She's made a stable relationship with a young man of her own age and has distanced herself from her father, not even giving him her current address. Her mother appears to offer some reparation in the form of her continued but non-intrusive support. Now I'm going to discuss this material, and I shall carry on. The weight given by both the patient and those engaged in her treatment to the role and meaning of her involvement in early and subsequent incestuous acts stands out in this account of Amy's history and therapy. Have these external experiences a specific role in precipitating the severe developmental distortion and delay which are the dominant features of the account? Or is the emphasis given to the sexual abuse aspect merely a contemporary idiom? For example, a metapsychology through which to view and interact with her internal disorganization. The term child sexual abuse has been adopted in the contemporary attempt to assimilate the significance of the finding that many people are involved in sexual acts by adults during their childhood. Implicit in the term is the notion of a damaging misuse of the child within the context of a relationship normally characterized by dependence and trust. There is growing evidence of highly significant links between child sexual abuse and subsequent emotional, behavioural and psychiatric disorder. However, no consensus is to be found amongst the differing causal models. Explanations based on learning theory and those based on the similarity with the post-traumatic stress disorder provide valuable but incomplete accounts. Breer's post-sexual abuse syndrome is descriptive rather than explanatory, but raises the parallel with the phenomenology of the borderline personality disorder. Summit, writing in Child Abuse and Neglect in 1983, describes the child sexual abuse accommodation syndrome. In his lucid and valuable paper, he describes the circumstances and psychological implications of sexual abuse in childhood, as well as some of the coping strategies employed by a child victim. Implicit in his account of accommodation are the distorting aspects of the abused child's environment and the impact of this on psychological development. Beyond the effects of the sexual act itself, such as pain, fear, overstimulation, and physical helplessness, he stresses the consequences of an atmosphere of secrecy and denial. An aspect of the child's bodily and emotional experience is denied access to parent mediation and empathic assimilation. The abusing father or father figure behaves as if the acts do not occur. The child's mother cannot be turned to through fear of her disbelief, retaliation, or through threats to keep silent. In this way, the abused child becomes emotionally orphaned. Within the psychoanalytic literature, there is, of course, an overwhelming body of writing on the subject of incest and abuse. In 1896, Freud presented his paper, The Etiology of Hysteria, in which he proposed that the origins of neurosis lay in the experience of sexual abuse in childhood. This was met with shock and unpreparedness, and he abandoned the point of view, going on to develop his theories of the inner world. The unconscious wish for an incestuous relationship with a parent became a central theme in his thinking, in which the significance of external events subsequently played a smaller part. In 1932, however, Ferenczi read a paper in which he gave an account of his treatment of patients who had been sexually abused. I quote, "Insufficiently deep exploration of the exogenous factor carries with it the danger that one resorts to premature explanations in terms of disposition and constitution," he warned. This was an early counterblast in a debate which has run and has a contemporary ferocity in, for example, the writings of Masson. Jung, on the other hand, wrote extensively and creatively on the part played by the idea of incestuous union in the development of personality. He appears to have had little to say about actual incest, but in the psychology of the transference, he comments, one cannot rid oneself of the impression that the death, he's referring to a psychic death, is a sort of tacit punishment for the sin of incest. A parallel concept is expanded by Schengold in his paper Child Abuse and Deprivation, Soul Murder, published in 1979. He provides a vivid analysis of the impact of emotional and physical trauma on the developing child. In his opening paragraph, he draws a sharp distinction between external and internal experiences. I quote, "I assume that actual, overwhelming experiences in the course of a child's development have a different and more profound destructive effect than do the child's fantasies of being overwhelmed by aggressive and sexual impulses." He goes on, "Soul murder is my dramatic designation for a certain category of traumatic experiences, those instances of repetitive and chronic overstimulation, alternating with emotional deprivation, that are deliberately brought about by another individual. Children can be broken more easily than adults, and the effect on them of torture, hatred, seduction and rape, or even of indifference, of deprivation of love and care, is the devastating one of developmental arrest." He describes two psychological mechanisms which the abused psyche can employ in its defense. The first is that of blanking out somatic and emotional feelings, a dissociation from consciousness. In describing the second mechanism, he points out that the abused child can often only turn to the abuser for relief of distress. I quote again. If the parent who is bad must be turned to for relief of distress that parent has caused, then the child must break with what he has experienced, and must, out of desperate need, register the parent as good. In his view, when a child is chronically exposed to an abusive environment, these mechanisms of dissociation and splitting can become permanent psychic features. In the case material which I have presented, these primitive defences are much in evidence. They are, I believe, exemplified by the image of herself presented by the first dream, in which she is both split and empty. Much of her behaviour up to this time, a constant hyperactive round of disruptive and destructive interaction, appears as formless chaos. I was helped to make sense of this in terms of her need constantly to evacuate her inner turmoil of feeling into the world around. In Bion's model, beta elements derived from the child's physical and emotional arousal are placed through projective identification into the mother, who can, through her receptivity and ego function, return them in a modified, assimilable form. It was this aspect of a containing parental environment that had been absent, through the sense of isolation and abandonment consequent on her incestuous relationship with her father. The failure to provide a receptacle for the overwhelming affects produced by the abuse led to the formation of persecutory, bizarre objects, of which the nurse-mother-rapist image in the second dream is an example. Good objects were placed for safekeeping outside, through projective identification, into idealized, fairly distant people. This often elicited the assiduous care and concern for Amy's well-being that she could not exercise herself. On the contrary, she had been possessed by the other split-off persecutory part object, and was compelled towards punitive self-destruction. The sadomasochistic relationship with her abusing uncle can be seen as an expression of this. Such profound division of internal world, with correspondingly split part-object relating projected into the environment, is a characteristic consequence of severe early trauma and deprivation. Borderline personality disorder and adolescence. What part does this early environment-induced disruption of object relations play in the formation of developmental distortion during adolescence? I believe Breer's observation of the similarity between the phenomenology of his post-sexual abuse syndrome and that of borderline personality disorder provides a useful link. The origins of borderline personality organization has interested many psychoanalysts and analytical psychologists, and the literature is still growing in volume. What has emerged is an interest in the psychopathology of the development of a sense of self, and a general agreement that delay or distortion of the separation-individuation process is central. Kohut and Kernberg emphasize the role of early deprivation. Masterson has extensively studied this subject in adult and adolescent patients. His formulation focuses on the rapprochement subphase of the separation-individuation process, as described by Mahler et al. Pursuit of separation-individuation is sabotaged by the mother's libidinal unavailability, resulting in abandonment, anxiety, and depression. Schwartz-Salient, conceptualizing this situation within an archetypal developmental framework, states, "The maternal figure has the powerful role of mediator in an archetypal process, and can use her capacities either to further the child's individuation or to severely undermine it." During adolescence, physical and sexual maturation bring a renewed sense of urgency to the separation-individuation process. the tension between individuation and dependent fusion with parent figures may reach crisis proportion. Much adolescent turmoil and psychopathology rests on the struggle to transcend this conflict. Because of this, some degree of borderline functioning is inherent in the adolescent psyche. This is not to say that adolescence is the cradle of borderline functioning, but rather a trial of life in which any deficiency in the capacity for separation individuation shows up. The result in those adolescent and adult patients who earn the label is a relatively permanent state of inner chaos and an inability to form stable relationships. As Schwarzschild says, in borderline patients, psychic structure is split between fusion states and extreme distancing, so that little or no real contact is possible. Amy exhibited most features of borderline personality disorder and those of Breer's post-sexual abuse syndrome. Her interaction with others, including that within the therapeutic milieu and with me, involved both extremes of fusion through projective identification and abandonment anxiety. In the case material which I presented, the three elements of my title are represented. Each element contains different but interconnected issues with which Amy had to contend. Borderline functioning during adolescence, with a history of sexual abuse in childhood. It's the nature of this interconnection that I wish to convey. I will comment on each element and trace their interconnection. First, borderline functioning. I find it difficult when working with a patient with a history such as this to extend reconstruction back in time to very early stages. The power of the central trauma of incest blocks the view. There's little doubt, however, that for Amy, inadequate mothering predated her sexual abuse, and that, at the very least, there would have been early failures to provide consistent and empathic parenting. What is clear, though, is that a non-facilitating childhood environment led to a fixed, maladaptive personality structure more or less corresponding to borderline personality organisation. Child sexual abuse. Her father, through his own immature need, had responded to the child's emotional availability with seductive enactment of her barely conscious impulses. These were due to her encounter with the power of the father archetype around 5 years of age. In this intrusion into her psyche soma, he violated and sabotaged what should have been a healthy struggle to integrate archetypal material. By concretizing the motif of incest, the father precipitated her into states of overwhelming affect within the framework of a fusion experience. Not only does her frail ego fail to act on this experience, but it is left simultaneously in a state of abandonment through parental disregard of her true self. She therefore dealt with the experience by employing primitive and self-defences, splitting, dissociation, evacuation of psychic content through reenactments, idealization and projective identification. Progress on the path of separation individuation was arrested, as true relating in vital libidinal areas had become impossible. The persistence of the abusive relationship through critical years of childhood maintained the conditions for the consolidation of a borderline personality structure. And adolescence. As a survival strategy, Amy employed a largely false self-relationship with her mother up to 14 years of age. She used the environment outside the distorted relationships of the family as a receptacle into which to evacuate and enact split-off parts of herself. However, with the resurgence of separation individuation needs, under the influence of her own sexual maturation, this unhappy equilibrium was disturbed. Further encounter with archetypal themes intensified and embellished the power of the already non-assimilated split-off fragments. In this way, persecutory, invasive, and self-denigratory feelings could not be defended against without an escalation of self-destructive behaviour. Her false self-relationship with her mother collapsed, revealing something of the truly destructive mother-infant dyad. This, her presenting symptom at referral, that is, hostility towards her mother and suicidal self-destructiveness, can be seen as the emergence of an impulse towards maturation and repair. This material and my experience with similar cases has posed for me the question that I raised earlier of what weight to give in the external reality of sexual abuse in both the assessment and treatment of disturbed adolescents. I have no doubt that it does play a special part in precipitating emotional developmental disturbance in which borderline functioning predominates. This is brought about by the traumatic and untimely intrusion of experiences derived from outside into the internal archetypal world of the child. The debate about internal versus external influences, like so many dualistic formulations, is sterile. Neither extreme point of view offers anything of real value for technique or theory. To admit that both external and internal factors are important is a step forwards, but even this adds only a little. Schwarz-Seiland, through application of Jung's exposition of projective identification, as set out in his analysis of the images of the Rosarium, makes use of a third area, which is, quote, neither inside nor in between people. He likens this to Winnicott's transitional space. I suggest that, although an event in real space-time, the act of incest, or an incest-like act of sexual abuse, takes place in this third area. From this arises its archetypal destructive power.
Seems to me difficult to, as you were saying, to proceed with therapy with these people, because suffering incest is a very important experience that your patients go through. But then there might be the risk that all her pathology is blamed on incest, which would be a paranoid view of her pathology. It's all my father's fault. But then you suggested that there was probably some earlier disturbance before the incest. So it wouldn't be appropriate for some of these people, well, for Amy and for other people like Amy, to come out of therapy, say, believing that my disturbance is because my father sexually abused me. Although it is true that certainly if my father sexually abused me, that there are serious consequences for me, but it doesn't seem to be the whole explanation, the whole story. After all, some people have incestuous relationships and they never come to see the psychiatrists. So all people who are described by psychotherapists or psychiatrists fitting in the post-incest syndrome, did you call it? They are all people who are disturbed. But there are also people who never come to the attention of therapists. So I feel uneasy about the role, the etiological role of sexual abuse in bringing about disturbance.
But,
Well, you're not the only one, Lorenzo.
I don't know that if you do have a patient who comes out of therapy blaming the abuse, it's the same as ascribing, as a therapist, ascribing some causative nature to the abuse. They're not one and the same thing, are they?
I'm not sure that I have followed them. When you blame the abuser, it's not the same thing as what?
Well, you're talking about etiology, aren't you?
Yeah.
And if we are starting to look at sexual abuse as having an etiological relationship to disturbance, I don't think it's quite the same thing as possibly a patient coming out of treatment saying it's all because I was sexually abused.
Making a distinction between the notion of etiology and a feeling of blame.
Yes. I mean, this question, I was actually startled that you asked the question in the paper, in effect, is the sexual abuse causative of disturbance? In that, working in child guidance, it seems it's taken for granted. You know, it seems obvious. So it's very interesting and arresting that you ask it afresh, and it's probably what you're following up, Lorenzo. And at the end, you make a very interesting suggestion that possibly it is because it takes place in a third area, a transitional area that's neither inside nor in between people. And it's a completely new idea to me, so I feel that, well, one observation I would make about that was that I think that what Winnicott is talking about is that stage of, much earlier stage of development when the small child is starting to differentiate between me and not me, me and mummy, and that the transitional object is that which partakes of both me qualities and mummy qualities in some way that's sort of in between and both. And it seemed to me that you were pinpointing, that you were suggesting that there was deficit certainly in that area of Amy's development, but that where you turn for thinking about the pathology is that area in 5 years of age, when you describe the impact of the father in its archetypal dimension, but you don't actually call it Oedipal, which rather struck me. Perhaps that's what you meant, in that what the little girl is struggling with is that she actually has physical feelings about the father. She does have fantasies about having daddy's baby and so on and so forth. And that's when and why she was so terribly vulnerable to father's, whatever one speculates, rejection by mother, being left out by the mother, second baby couple and so forth. And that when that becomes actual, when her fantasies, which are what Freud described, her fantasies of union with the father and replacing the mother and so forth become concrete, that interference with the development, which should be renunciation of those desires and an internalization of, let's say, a creative parental couple, when that's interfered with and something concrete actually happens, then there's a failure to develop a symbolic capacity, and there's the remaining concrete thinking, and other distortions go with it, the splitting and so on and so forth.
Yes, I go along with that. I mean, I think my suggestion is for me a very sort of speculative exploration. It's an idea that I haven't really developed, but what you're saying, Miranda, is right along with that. I mean, and the way I was thinking about it, and the sort of shorthand use of what phrase I used there, archetypal process, is meant to imply, yes, that exactly as you described, the Oedipal stage, and the girl's potential availability within that experience for some sort of fusion with the father.
Yes, and turning to father for maternal comfort, which she was lacking. I was very struck by the fact that she never let mother touch her. So there's a whole area of sort of skin experience and sense of self that you also discuss. It seems to be missing.
It seemed to me very fortunate for this girl that she had the containment of this institution where she could act out her concretized, violent emotions, and what a terribly valuable thing that was for her, and how perhaps there's some link between the sexual abuse and the enacting of a fantasy, which makes it very difficult for this little girl to internalize and allow herself fantasies, because they are so frightening.
Yes, I mean, I think that as I stressed in that the adolescent unit as a container for this is a vital ingredient without which there could be no therapy, couldn't have been any effective work with her at all.
I was very struck at how effective the work was, and on once a week. I think it's very remarkable.
Well, it's on once a week or 7 times a week, if you see what I mean, because she was there 7 days a week in the whole environment.
But you saw her once a week.
I only saw her once a week in that framework. Yes. But in a way, what my account is the story of in a sense, a whole team working with the person, rather through the eyes of one member of the team, rather than the one in the individual therapist role, rather than as one might describe the outpatient therapy or the therapy in private practice through the sole therapist's point of view.
I noticed that you use the term incest in the title of your paper, but within the paper you're using the term child sexual abuse, and the two seem to be used synonymously. Now, this particular patient was the victim both of incest and paedophilia, and I believe those two groups of victims do have characteristics in common, but also different ones, and I wonder if you'll comment at all on that, and perhaps about this patient and others in the unit, whether you actually do distinguish between the two. The research that you've quoted seems to move towards an umbrella concept.
I used the word incest, both terms, incest and child sexual abuse, deliberately to open up really some of the... you see, I think the point you made, Lorenzo, about the role of child sexual abuse or incest as an etiological factor in her disturbance is still an important point. And although as I say, I'm quite certain from my experience of working with many such youngsters now that it isn't just that they are disturbed people who happen to have been sexually abused, and that's part of the story. I've come round at a direct experience to the belief, rather than the sort of scientific certainty, that the sexual abuse experience has a primary central etiological role in their current, in their subsequent disturbance, and that isn't just a factor on the way or something that they couldn't deal with because they were already damaged. But I think that's a very interesting issue, and the reason also that I used the two terms is because I think that you see that we've gone we've gone through a social revolution in the last 15 years, where a phenomenon called incest was discussed in many ways as an idea, as a motif with a lot of meaning, or as a quaint practice believed about some other people in some other place or another time, or in the books of mythology as themes in mythology. And we've moved into the deliberate invention of a term, child sexual abuse, which is a much more specific term, and it seemed to me useful to mention both these things in different ways and juxtapose them, I think, because there is a major shift in thinking around the incest as an idea and child sexual abuse as a fact, and I think those two, this separation is very important, and we can still have incest as an idea for all sorts of purposes, and but we must think very differently and very seriously about child sexual abuse as an actual damaging part of people's lives. So that was the main thing. But the second point, in my unit, where we have a very large number of youngsters, both sexes now over the years, with child sexual abuse in their story, I can't say that I really have felt there to be I haven't experienced there to be a significant difference at first hand myself between child sexual abuse of an incest form, in that it was a parent or a parent figure who was the abuser, and someone subject to a sort of paedophilia relationship with a non-related or non-caretaking adult. And one of the reasons for this is that we have found the disturbing discovery in our very limited series of cases that while, as in this case of Amy, the child may begin telling you about, as she did, a one-off incident involving a stranger, and then move through degrees of relatedness. In most cases, they end up, if they have, when they have done sufficient work on developing an internal empathic mother, telling you that the first abuser was the father. And so in the end, all our children subject to paedophiliac interest turn out to have been abused by their father. And this is an almost 9 out of 10 finding. But of course it's within a very small group of very severely disturbed people, so my own perception of this population is looking at a very narrow band out of the very large number of people that have actually experienced abuse, which we don't know about.
I was wondering whether you'd find there was a difference with the age at which the child was. Well, you don't know when it was originally abused, but as declared, and what the relationship. I mean, it's often felt that the parents of an abused child have been abused. And the third question was that it used to be held that a boy that was abused by his mother was a much more serious condition than a girl that was abused. It produced much more serious psychopathology than a girl that was abused by a father. I don't know whether that still is experienced.
I really can't comment on that. Actually, I don't know, and I've no real experience of. I haven't enough experience of such cases to make any comparison.
This particular patient to me seems to show some of the characteristics of perverse mothering already, and a female sexual perversion rather than of male perversion. So, she would be in that cycle, I would have thought, had she not had the treatment that you offered. But one thing might be why boys are considered to be more disturbed than girls is because far fewer boys come to light, and the ones that come to light are because the mothers who are abusing them are themselves very, very disturbed or are doing something very public. But most of the cases, I don't know what it is in children in your unit, but
most of the boys, abused boys we've had, have been abused by their fathers.
Yes.
In fact, I only have an experience with 2 boys where they have disclosed that there's been sexual contact between them and their mother. So that the my experience bears out some sort of general findings that the vast majority of abusers are male, as far as is known. It is a male activity, really.
Of course, there are people who are disturbed and have never been sexually abused when they were small. And it seems to me...
Yeah, that's true. Yeah.
Yes. And it seems to me that this girl is continually abused by this state of mind that comes about at certain times, which makes her, and she describes it very well, and I think she's a very interesting sort of patient in that, with that precision with which she describes this madness. And when she's mad, and then she steals, she drinks, I suppose, or that's the way I would view her. But when that state is into operation, she drinks, it abuses her, not in the past but now, in the present, by destroying her life. So that she drinks, she gets into trouble, she steals, she gets into trouble. She goes, presumably, to babysit, when she knows very well that her uncle will behave in certain ways to her, because it seems the abuse sounds, the sexual abuse sounds a repetitive one. So of course she knows, after she has experienced it once, the second time she knows what to expect. And because it seems to me that because of this mad state of mind, she will go for it. She wants to protect herself by not exposing herself to a dangerous or abusive external situation, but she will go for it. So it seems to me that there is this internal abuse that takes place 7 days a week, 24 hours a day, sometimes more intensely, sometimes less intensely. And that's perhaps the main problem that she's got.
Yes, I think that's right. I think I put it very well there. And that's a picture I think I find repeatedly. A girl in the unit last week who had been admitted because of repeated self-injury, which only developed as a habitual behaviour during the 6 months following her disclosure that she had been abused by her father, and taken into care, was referred to us as a girl who's constantly attacking herself with razors, broken glass, overdoses, alcohol, anything, each dose something else. She was either intoxicated or cutting herself, and
well, this goes back
to our dismay, she gave up self-injuring very recently in the unit and started visiting home again. And after coming back from visits to home in a sorry state, all tense, and and then the nurses have said, well, what did you go there for? What happened? And she said, I can't say. So eventually the other days we said to her, you're going home to be hurt and abused because you've given up doing it to yourself. Have you gone back to having it done to you? And she used to say, yes, I think so. So there, she has this exactly the same compulsion to
self-injury in a way. Of course, she might go back to her home to experience further abuse, even if there wasn't an abuse of a sexual nature. There are all sorts of other abuses that she might experience when she goes home. In her particular case, it is a sexual one, but there may be other abuses, like double messages, double-bind communications.
But there's also the abuses there from the mother who says nothing has happened when something is happening, and that is an abuse.
That's an abuse, yeah.
She's perfectly all right. She's fine up to 14.
She's got a very abusive mother, yes.
Yeah.
But you see, what I think is to say that the person is has a compulsion or a habit now to experience this is not saying enough, and I think that to look at you see in the case material, I feel the thing I called the rapist nurse mother is a sort of conglomerate, a bizarre object which is by which the patient is sort of possessed. It has to be dealt with. It has to be given its this experience. This part of herself has to be given its expression because it is a part of her. It's not just an idea in a dream, as it were. It's a part of her, and it can't exist inside her because it's too unpleasant. So it can only exist in the form of an interaction between her and someone else, and then it becomes sort of vitalised and can exist, but it can't not exist. It has to have its part of her in her life.
Is that the only time you feel alive? In some way? I'm not sure what I mean. But this girl doesn't feel.
No, she said yes. That I'm not sure about this patient. I've certainly had patients say that, but I don't think it's the only time, because the other thing that I was very struck by in her case was how she swung after eventually telling me about the first abuse, which is by the father at age 5, to telling me that the only time she had ever felt alive was when was in the context of her relationship with her father. Although she had feared him, she'd been hurt by him, she was intimidated and overwhelmed by his cruelty and his coming and going and his threats and so on and so on.
So that's love.
He was the sunshine in her life.
So that was love, from her point of view.
Yes, I suppose so.
But isn't there something else happening there which helps to explain the going back to the bad parents? And she didn't have one good parent, she had two bad parents. She lived right into adolescence without telling anybody about this abuse. And she would have had to protect her parents, to protect her father certainly all that time. So she would have had to be telling lots of people about her good parents, or at least her adequate parents, which would have fed into her fantasy, which she must have had, that she had good parents as well. Somewhere she had good parents, or that her parents were good. They were so bad that she'd have to create for herself these other parents that weren't like that. And I'm not sure that going back to see the parents isn't partly to go back to resurrect the good parents, which she has fantasised, and she always hopes to create in reality when she goes home. And which she's lived with all through her childhood, because she's never disclosed what happened to her.
I wondered if you had any picture of how she coped with abuse when she was 5. I mean, what she did about it, and how she coped in her mind with it.
I think the nearest I can come to that is to say that she didn't know it really happened. She didn't really experience it as happening. It's a bit of a poor response, but there was no real memory of having been abused or of living at the time. Her memories of that time were of sitting on her father's shoulder when he went out to meet his friends. As a tiny girl, a little child, memories like this, or memory of mother and father fighting and arguing. These are intense, vivid memories. But she has no conscious memory, really, of abuse. Although there are one or two little things which she has come near to talking about and cut off, and so the quality of them being like badly remembered bad dream fragments is very great. Now, I was thinking about what you were saying about her need to tell the world that to hide to keep the secret and tell the world her father and mother were really adequate people, as reinforced. Reinforced her.
Split, I'm trying to see it.
I really try to formulate something that's actually the other way round, and I feel that you have to put oneself as far as possible into the mind of the child. That it isn't possible for her to conceive of her parents in any other way, except as being good as well as bad. So it isn't that she had to tell a lie and then start to believe it. Rather the opposite. That the damaged, abused child does not believe that their parents are also good, because if they were to do that, they would. It's an impossible. To me, it seems like it's an impossible formulation for the child. It's only in retrospect that with a degree of maturity that the adult can say, my parents were less than good.
I mean, is it almost as though they don't know there's any other way of it being?
Yes.
I can't go along with that because she must have been telling lies from quite an early age, and probably encouraged to do that. I mean, it's rare for a perpetrator not to threaten a child.
She certainly was, yes. I agree with the woman. She was threatened
If she
and lying.
actually split it off, she wouldn't need to tell lies. If she dissociated sufficiently efficiently, she wouldn't need to.
Well, I think this is where I come to this rather tenuous formulation right in my last sentence, which is a bit tantalising because I haven't really worked this out. You see, I think we're talking about something which is in both areas. It's something that from her conscious experience of what happened, she had to lie about. But from another part of her experience, it didn't really happen anyway. It didn't need lying about because her parents weren't bad and such things wouldn't happen. But they did. So, and I think it took place in that area.
Miranda, you had something?
Yes, I wanted to come back to the questions about the girls who return to abusing parents or are abusing themselves, because I think it takes us back to this period when in normal development the incestuous wishes are not enacted, and the sort of way of passing through the so-called Oedipal phase has to do with being able to internalize parental figures so that they can go on functioning in a creative way in the internal world of the child, and that when that process is interfered with, the development is arrested so that at a concrete level, so that the child who is suffering, the mad, bad, small inner child, is attacked and murdered and got rid of in a concrete way, a again and again and again. And this is linked to what you were talking about of the discharge of the beta elements into the environment. So that actually, to me, the dream of the raping mother is progress in the capacity to symbolize the disturbance. By the time it's got to a dream, already it's a picture and can be talked about with you.
Yes, that's
It's got some as if.
She's, yes, and she makes very remarkable progress in the dream images towards symbolization.
Yes, I think that's very useful. And what goes on in the adolescence unit as this container is earlier stages in that process, so that they are, as it were, I often think of the unit as this sort of organic container, collective of therapists. And so earlier on I would hear, say weeks before that she was able to bring me the dream, I would hear, Amy had a terrible night. Amy was out of bed, this is nurse's report, out of bed 5 times in a state of shaking terror, inarticulate, no explanation of what was happening. She was unable to discuss it, but was, given tender loving care 3 times and eventually settled to sleep by 6 a.m. sort of thing. So this sort of thing would...
So 24 hours accurate mothering and mirroring.
Well, it's not always accurate. but I think that fits very closely, that eventually, through that experience, eventually she's able to bring a dream image to the therapist, rather than these disturbed nights to the nurse on night duty, who is being part of this mother container.
Did you have...
Well, just by amazing coincidence, I just did an assessment, which was an abuse assessment, but the hour before I came here, so I'm all ears trying to learn quickly. And this young woman was talking about having been sent from Jamaica to here, aged 15 3/4, nearly 16, to become the child of her father's sister who didn't have a child. And she described her father is strict, but her parents is good. And then she was abused or molested, although there was not full intercourse, by the aunt's husband over a couple of years. But she was exhibiting all the symptoms of the post-child abuse. And I was thinking, why is this such a severe reaction? Because she doesn't seem that young. So now what you're suggesting to me is that maybe there's a whole kettle of fish. That's probably what it is, isn't it? I mean, I was going to say it from the point of view of, in another point of view on the whole thing about, does the abuse cause the pathology, or, but it sounds like maybe there's a lot more abuse to come.
That would be my guess,
Yeah.
from my experience, that many patients tell us first. It's like reminds me of the transition that goes on in adolescence from from parent figure to peer, as in normal adolescence, of sort of primary attachment figure, and you get this movement away from the parent till eventually it goes through being the games mistress's husband to the pop star, or is it the pop star? And eventually it comes down to the boy next door, or the girl next door. Well, you get that the other way round with sexual abuse disclosure. They start off with some bloke that they met in Bognor Regis last summer, and they end up with daddy. And tragically and sadly, in my experience, it 9 times out of 10 it actually comes back to daddy, But the journey is very long and difficult, and many people, apart from the sexual abuse victim, wish to arrest this journey at a very deep psychological level. They wish to say, that's enough, surely it was that, it was the red coat at so-and-so, or it was really the uncle when she went on holiday when she was 12, for the first time away from the home, or something like that. We don't want to know anymore. But I always now feel these events are part of what you were describing, Lorenzo, the being now vulnerable to someone coming in to elicit this persecutory part object attack on her through a repetition of the abuse. And its origin lies usually much closer to home and much more close to the developmental process.
Yes. And these people are very vulnerable to continuous abuses, so that all their relationships will be abusing ones, with the husband, with the boyfriend, or whatever. Also, when they become patients, they are vulnerable to being actually abused
by their therapist,
or staff, because who is attracted to work with children? I mean, you work with children, but they are excluded out with this. And they say that a lot of these people are abused by the staff in either child guidance clinic or whatever therapeutic environment, or social workers. So there seems to be something in them that calls for more and more abuse.
I would be interested to know how you handle confidentiality within a residential therapeutic milieu, because confidentiality with an abused, sexually abused child or adolescent is a very, very dangerous thing. I think at least as they feel it.
Well, we have two principles. One is that the boundary of the unit and its team is the envelope of confidentiality. So we don't talk to anyone outside the unit. And the other principle is that inside that envelope, confidentiality is what we call limited, and can't therefore be extended to cover material relating to sexual abuse. So if you talk about sexual abuse, say to your therapist or to your key worker, it will be reported to the entire staff team.
We have to, I'm afraid, leave it there. If we would like to go on, all of us, but our time is up. Thank you very, very much.